So as people come into the room, we're going to get underway with this afternoon session. As I said a few moments ago, you're a very warm welcome to our afternoon session here, and I think this will be a particularly interesting and important session for you, which you will find, I'm sure, very rewarding. I think from my perspective, and I'm Darren Kilroy, I'm the Medical Director at the Countess of Chester Foundation Trust in the Northwest. The context for this session for me on a personal level is very important. We were an acute provider hit very hard with COVID-19. And the vast majority of our bed base became one of extremely high acuity patients. And the impact on that for all of us in the workforce was profound and continues to be so in many different respects. So on a personal level, this is a very important session for me, and I'm very honoured to chair this in the company of some esteemed colleagues who I know will be sharing with you some of their own reflections and very importantly, the learning that we can all take from their experiences, from their different perspectives in managing the pandemic, and more importantly, of course, how we then go forwards from that to now, where we are now, and how we take that learning forwards into what will undoubtedly be a very challenging summer and winter and beyond, and who knows what the future holds there. I'm not going to spend much longer in terms of any introductions, because it's important we get on to the actual meat on the bones in terms of what our contributors have to say for us this afternoon. What I would say would be, please play as ever. Please pay close attention to what's being said. There is the opportunity for us to ask questions towards the end of the session, and hopefully that will be an opportunity for you to interact, because these sessions are always much more rewarding if we have a conversation and a dialogue as we go through. So without further ado, I'm going to hand on to our first speaker. We have three speakers for you in this session today, as I say, bringing their different perspectives. Prathibha is going to open up for us. I'm going to let the speakers make their own introductions, because in my experience, when you're in a session like this, the way in which speakers introduce themselves and the context they give to why they're here today it contributes very significantly to the content of what then follows. So without further ado, I'm going to hand over to a fellow Northwest colleague and hear from her experiences in terms of the impact of COVID-19 from the work that she's been doing. And I think you're going to enjoy this. So Prathibha, over to you.
Thanks, Darren. Really delighted to be part of this symposium. And as you've said, this is such an important discussion topic for all of us. So I'm a clinical academic working in Greater Manchester, and I was involved with others in developing the mental health response following the arena attack in 2017. And we set up a number of clinical care pathways, including support for staff. And last year, we expanded the remit of the Greater Manchester Resilience Hub to include the impact on health and social care staff across Greater Manchester. So what I want to do over the course of my presentation is really to share some of the learning from those experiences. If we move on to the next slide, it's just a huge thank you to both the research team as well as the clinical team that have supported this work. And on to the next slide. I'm going to just summarise some of the sort of key aspects of the evidence and learning, and then I'm going to go on to talk about some of the principles and what that means in practice as well. So if we just start off with some of the kind of key points from the evidence base. So it's just remembering that staff, just like members of the public, if we're exposed to any sort of major incident or pandemic, that we're going to present with a whole range of different symptoms. So this isn't just about anxiety or depression or PTSD. It's recognising that there may be problems with substance misuse, with sleep, with bereavement. Some of our staff might have problems with eating disorders or psychosis. So the range of presentations, but also the severity of presentations can be quite varied. And also just recognising that particularly in the acute phase, quite high levels of distress might be quite common. So there was a systematic review that suggests that in the acute phase of a pandemic, 50% of healthcare workers might present with quite high levels of symptoms around distress, but a smaller proportion may go on to continue to have mental health symptoms and develop disorders. So dropping from about 50% to 20 to 30%. The other, I think, key element just to recognise is that it's not necessarily just the incident or pandemic that actually causes the problems. Often it can be secondary stressors. So we just need to be mindful of that, I think, when we're supporting staff. So with COVID, some of you will be very aware that some of the COVID restrictions have had a huge impact on relationships. We've seen nationally real concerns about rising rates of domestic violence, lots of concerns within families about the impact on finance. So I think just be mindful of that when we think about support. It isn't just the incident or pandemic that causes the stress. There are some key differences when we think about providing support to healthcare workers. And I think it's just recognising some of those key differences. One is the impact of moral injury. So moral injury happens when clinicians are asked to make decisions clinically, which is against their sort of ethical or moral framework, often because of restricted resources. And often it's more likely to happen when there's a higher association with death and mortality. So we can see the particular concerns arising with COVID. Repeated incidents of moral injury can increase your risk of moral distress, which is much more likely to be associated with increased risk of developing mental health symptoms or mental health disorders, including PTSD. And some of the most effective strategies to address moral injury actually are around prevention. So supporting clinicians around complex decision making, supporting team working, and really giving teams the opportunity to really reflect on what's happening and decompress as well. The other two elements I think are really different about supporting healthcare workers, which can be a real challenge, is that we're much less likely to identify ourselves as having a mental health need. And I think we can probably hypothesize the different reasons for that. I still think, sadly, there's still stigma attached to mental health problems, and something that we do need to tackle as organisations. But other factors, particularly in the acute phase, we know that healthcare workers, again, are much less likely to identify themselves having a problem, because there's a strong focus on the patient, really wanting to support our service users, people accessing services, but also real concerns about letting colleagues down. So we've seen, and again, we've seen this in Greater Manchester, where in the acute phase, last year we sent out, I think, 6,000 emails last August. We only got a sort of 5% response rate at the time. But interestingly, since January, as we moved to the recovery phase, we've had more and more staff actually contact the hub. So at the moment, we've got 500 staff that we're supporting directly. And our anticipation is that as we move into recovery, we'll see more staff actually coming forward to support. Longitudinal studies, so some data from Paris and 9/11 suggest that it might be 5 to 7 years after an incident that staff actually come forward to access support. So it might be a secondary event that actually causes further deterioration in their mental health or a shift in their health-seeking behaviours. And interestingly, with GM, we've actually found staff now accessing support that were originally affected by the arena attack 3 to 4 years earlier. So we really do need to think long term, because it may be years down the line that actually staff come forward for support. The other, I think, key elements to just identify around some of the research evidence is just recognising staff groups that might be more vulnerable to being at higher risk of developing mental health problems. So we know that exposure may be a factor. So there was an article in the BMJ last year that did suggest that staff that are more directly exposed are at greater risk. And we know there's been data really looking at ICU staff and the particular concerns about their exposure during COVID. Staff from Black and ethnic minority groups, again, the particular concerns about their experience through COVID. Other risk factors include more junior staff, so the impact on trainees and students, but also staff that are new to post. So with COVID, real concerns about staff that were redeployed into new roles, maybe staff that have been promoted into different teams or into new positions. And finally, really kind of recognising that staff with pre-existing mental health problems or disabilities might also be at greater risk of deteriorating with additional stressors. So if we move on to the next slide, this really kind of takes us through some of the kind of key principles to think about. So given some of the kind of learning from previous incidents, you can probably recognise that we've got to be proactive. We can't passively wait to develop a response given what we know from the evidence base. The response also needs to be graduated. And by that, I mean, if we think about the pyramid from the previous slide, you'll see that as organisations, we ought to be thinking about that sort of prevention, early intervention opportunity. So how do we support a resilient response in our staff? And there is quite a lot that we can do as an organisation. But then as staff are developing mental health needs, how do we ensure rapid access to specialist assessment and support and treatment? And this is really about how we link some of our occupational health offers with the staff wellbeing hubs that are being developed. Being flexible and culturally sensitive is really recognising the diversity of our workforce. So 20% of our workforce would identify themselves as being from a Black or ethnic minority group. So it's really recognising that not just ethnicity, but religion, gender, sexuality, disability, there's so many factors that influence the type of support that we want. So rather than assuming that one offer is going to actually be the right offer for all of our staff, we ought to actively listen through our different forums to sense check the kind of support the staff want. And our learning through Greater Manchester, but actually also nationally, is that staff want choice. A lot of staff will want support within their organisations, so through teams, through occupational health, but actually we also know that a number of staff want their support external. They want it anonymously. So giving staff choice is going to be really, really important. Building capacity and that system leadership, again, I'll touch on this in a little bit more detail, is really thinking through how we strengthen that prevention and early intervention offer. Identifying vulnerable staff, so really making sure that all of our team leaders are really aware of some of the evidence base and how they identify staff that may be at greater risk of developing difficulties and being proactive around the support that they require. And supporting recovery over time is really recognising that actually staff are much more likely to access or want access to services later. And this is one of the areas that unfortunately we didn't get right within Greater Manchester. Following the arena attack, sadly, organisations shut down within 8 to 12 months. The pressure to move to business as usual was so strong. At the time, there was still a culture that if we started to go into organisations to ask about how staff felt, that would cause some sort of decompensation. We really need to understand as a system that actually we do need to look at the wellbeing offer in the longer term, because staff may be needing support 5 to 7 years down the line. And what we did with our learning from Greater Manchester, and we worked with colleagues in Grenfell and London Bridge at the time, we synthesised some of that learning into the EPRR NHS England guidance around mental health. And in it, we talk about really thinking about support in the longer term, so 5 years plus. So if we move on to the next slide, this just kind of talks around some of the staff wellbeing hub offer. So some of you will be very aware of the national rollout for NHS England. So we've set up sort of staff wellbeing hubs across STPs and ICSs, and the full functions that hubs have been asked to develop. One is around proactive outreach. The second was around building on the current support offers. The third was around rapid assessment, and the fourth was about care navigation into specialist support. So within Greater Manchester, what we've done is we've looked at a number of those different functions. We've coordinated a variety of resources and really wanted to ensure that was kind of disseminated across the system. We worked with health departments, and I guess a plea out to exec boards and senior leaders is take this as an opportunity to really do a deep dive around your occupational and EPA offer. It's incredibly varied. That's one of the things that struck us. I would strongly suggest that if you haven't already done this, at an ED and NED level, that you have a staff wellbeing lead, basically. And this needs to link to your HR offer, but it needs to be separate. So really making sure that at that senior level, staff wellbeing is really a priority. When we looked at some of the wellbeing offers across organisations, it was incredibly varied. So some organisations offering counselling, that's a limited evidence base for very few disorders. And actually, we were slightly concerned that counselling was being offered in a non-evidence-based way. The strongest evidence base for me is really staff wellbeing psychologists. So they have clinical expertise, not only to recognise when to intervene for a practitioner, but actually they understand systems thinking. And some of the most effective work within an organisation is how we increase the skills and capacity of systems and team leaders to support staff wellbeing. So really looking at investing in staff wellbeing psychologists, and some organisations I think had the odd day of a staff wellbeing psychologist. If you're a large organisation, that really isn't enough. So this is really an opportunity to invest in that prevention, early intervention offer. Lots of proactive outreach. We kind of went out to the system for them to identify high risk environments, but also just kind of highlighted some of the evidence base from research, the ICU, ED departments, older people's wards. We've done a lot of work with care homes, but actually asked the system where they thought the pressures were. A lot of our work isn't necessarily directly with a member of staff, it's also with teams. That's where we have some of the biggest impact. So we've supported a lot of common room discussions with team leaders so that they're aware about trauma, moral distress, moral injury, and how to recognise staff, but also really supporting the system to think through what it might need as well. And with a direct support to staff, what we've done within GM is that we've actually have a link. Staff come into a series of screening questionnaires that they complete. They're then sort of rated and categorised into sort of red, amber and green, depending on how they sort of complete those questionnaires. Anyone that rates sort of amber or red, we then have a follow-up call with them directly to understand whether they need more specialist support, and we repeat that screening over time. Our support offer we keep very flexible. Staff can phone up, they can access information on our website as well. So if we move on to the final slide, I'm just going to talk through some very practical things to think about as a sort of exec board and as senior managers. So compassionate leadership is going to be one of the biggest challenges for us, because we know that we've got this really challenging situation of dealing with exhausted staff, business as usual, COVID, as well as managing the backlog. So how you manage that narrative, I think, is really quite challenging. And we've got to make sense of that as an exec board and think through how that narrative is disseminated through the organisation. And as well as talking about compassionate leadership, we have to demonstrate that. So the modelling through the system, I think, is important. Linking up clinical care pathways, so reviewing your health offer and making sure that pathways are linked to your regional staff wellbeing hubs is really important. And then with the messaging, really looking at opportunities for validating staff's experience and really ensuring that staff feel valued. This has been a challenging year at every level. Short rounds, opportunities for reflection and learning, so that conversation about what's worked well, but what do we need to do differently. And we often talk about ensuring that all of our staff have access to physical as well as psychological safety. So we use a narrative of not just physical PPE, but actually psychological PPE. What are the practical things that we can do to really strengthen staff feeling safe? So practical things like strengthening team working, so check-in, check-out, buddy systems, team leader training, so that all of our team leaders are really aware of trauma, moral distress, mental health symptoms, and they know what to do if there are concerns about more specialist support. Making sure that we're using appraisals, IPDR to strengthen well-being. Containing the containers is really about strengthening that system response. But also the other element is coordinating resources. So a lot of staff say they feel a little bit overwhelmed about the different support offers. And we know that actually we have to repeat these offers over time. So it may not be now that actually staff are looking for support. It may be 12 months' time. It may be 3 years' time. So how you make sure that we increase awareness. So team meetings, posters, screensavers, just think about how we keep disseminating the information about the support offer, because often it just depends when that staff member is at the right point to access that support. do look at opportunities to have that facilitated group discussion. So whether it's through your health department, your staff wellbeing psychologist, some organisations also have access to liaison mental health teams. So having discussions with them about whether they have opportunities to support staff as well. And also linking to your local staff wellbeing hubs. That's been quite a lot of the support we've provided in GM. And then finally, just some of the kind of key principles about staff empowerment. Some of you will be very familiar with Caring for Doctors, Caring for Patients, that was published for the GMC by Michael West and Dame Denise Coyer. And it's really about, in reference to doctors, but actually I think this is true for all of our staff working within healthcare settings. So it talks about staff really needing to be supported, about working in an autonomous way, belonging, but also feeling competent. So really thinking about how we empower staff and manage that narrative that we need to have an opportunity for recovery, but also engaging them in some of those discussions about how we move forward, how we take some of the learning from COVID about working differently and smarter and more efficiently, but engaging staff in those discussions I think is really important. And then finally, just finishing by saying we've got to look at all the different sources of data to get a sense of staff wellbeing, both formal sources of data, so wellbeing surveys, vacancy rates, sickness rates, but also informal sources of data. So really listening from team leaders, but actually talking to frontline staff gives you lots of information about how they're working or feeling at the moment. So I'll finish there and just to say thank you very much for inviting me to this session.
Oh, thanks ever so much. That was a really interesting session. Huge amount of content there. I wouldn't know where to begin to pick out one element of that presentation that was more important or less than the other. That's a superb presentation. Thank you ever so much. In the interest of getting a rounded set of narratives in this session, what I proposed was if you have a question arising from that session, then pop it into our question box and we'll come to it as we go along. But to keep the context broad and to weave different perspectives in here, I'm going to move on and invite Joni to talk to us now. Joni is joining us from the King's Fund, where some really interesting research has been going on, which I think will complement what we've just heard really well. So Joni, I'm going to defer to you with your slightly less scenic background than the first one there, but the King's Fund background is well known to all of us and is usually the hallmark of a high quality piece of work. So Joni, we're in your hands. Thanks.
Oh, thank you, Darren, and good afternoon, everyone, and thank you for having me here today. So it was really good to hear Pratibha's presentation there, and hopefully what you'll hear here is a building on that, but also slightly broadening out some of the findings. And what we did at the King's Fund here is we looked at what we can learn from other disasters that might help our recovery from COVID-19, looking across the UK, but also internationally. And I'm really pleased to have this opportunity to talk to you today. And although I'm the one presenting here, you can see from this slide that this work is a result of a much wider research team at the King's Fund. So if we can move on slide, please. So for the next 10 minutes or so, I'm going to take you through what we found out about other disasters, like I said, both in the UK and internationally, that might help inform our recovery, particularly with regards to the health and social care workforce. And if we can go to the next slide, please. I guess it's quite important and something that Pratibha has also mentioned about the long-term nature of recovery, but it's really important also to note that recovery is non-linear. And what we found in our research is that recovery is less exciting, is less researched, and has less guidance available than the response phase, but it's no less demanding or exhausting. And also to note that recovery is a process that takes years and not months. Experience has shown that the recovery phase and the structures, processes, and relationships that underpin it are harder to get right than the response phase. It's not a tick box exercise with a well demarcated end. And I'll leave this slide here just for you to decide where you think you are on this graph as an individual and as a nation. Can we go to the next slide, please? So what's needed for a successful recovery? It's worth noting that most people have an extraordinary capacity to recover from disasters, but there are marked differences about how people recover from a disaster. And there's lots of interest in trying to identify why some individuals, communities, and systems seem to recover more successfully or cope better. And that turns out that they tend to be more resilient before the disaster strikes, which is why it makes sense for recovery to be focused around building resilience. And when we talk about resilience here, we're talking about the ability to withstand, to cope, to adapt to disaster, and to be better prepared for the next one. Resilience is often thought of at three levels: individual resilience, community resilience, and system resilience. And next slide, please. So the NHS has a tendency to focus on system resilience and individual resilience. But we think in this research, we found that the focus felt right to be building community resilience. And the evidence suggests that by building capacity of communities to be resilient, you're making sure that both individuals and systems are in the best possible health to cope with the impacts of a disaster. It's also really worth noting that when we're talking about individuals and communities, that the health and care workforce are indeed that part of those communities. So when we think of the focus on community resilience as the right thing for the following reasons. So most people get their long-term support after a disaster from the people around them rather than statutory services. Individuals cope better, are more resilient when they feel connected to the people around them. They have connected communities. Focusing on the community also stops people blaming individuals for not recovering well. The "aren't you over it yet" question that makes people feel that they are failing for lacking resilience. And finally, you can't have a resilient system without understanding what the community needs and having them at the heart of recovery efforts. Early on in this research, we heard people describe their part of the NHS as not being particularly badly affected by COVID, and that it would be relatively easier to resume services to patients. But whilst the hospital might be up and running quite quickly, they pointed out it might take decades for individuals, including staff and communities, to recover. Next slide, please. So from our research, we found four main elements which we felt vital to building community resilience here on this slide. But for the purposes of the talk today, I'll focus solely on supporting the health and social care workforce. And some of this is, really building on the stuff that we've just heard from Pratibha. So that's a great place to start, really. But if we can go through what we found out in this research too. So next slide, please. So why focus recovery efforts on supporting the health and care workforce? Well, the health and care system play a central role in building community resilience. And in turn, this means ensuring staff in health and care services are given the time and support they need in order to recover, to ensure that they can continue to work in health and care services in a supported way that is not further detrimental to their own health and well-being, to avoid large numbers of staff leaving the service, which in turn would increase the stress and strain on the remaining workforce, and finally, to ensure system resilience, which is vital to help support build resilient communities through their everyday contact with the local population. Next slide, please. So what can happen after a disaster to a health and care workforce? So we've heard some of this just earlier in the presentation before, but when communities experience a disaster, it's often the health and care workforce who deliver services at that front line, dealing with a range of complex challenges such as lots of death and traumatic injuries, increased demand pressures with increased patient load, which often doubles up then with reduced resources as health and care workers are themselves affected by the disaster, or their families, or the concern for their own safety results in a decrease in the available workforce. And in the case of viral infections, we found, such as SARS, swine flu, and the Ebola virus, it's also included the need for personal protection. And as a result, the health and care workforce are at an increased risk of developing mental health problems such as PTSD, depression, anxiety, compassion fatigue, and burnout. Next slide, please. There are several examples we came across in the literature and interviews about the impact of disasters on the workforce. For example, Immediately following the worst earthquake suffered by Japan in Fukushima in 2011, around half of all healthcare workers did not show up for work, and that number of staff had not fully recovered 18 months post-disaster. And there are lots of complex reasons for absenteeism, such as psychological fear, disruption of supply of commodities such as food, fuel, and means of transport, and a concern for family safety and well-being, particularly those with young children. Research also found that nurses in Fukushima still had greater stress levels than the general population 4 years after the disaster. And similarly, with regards to the SARS outbreak, researchers found that staff who had been in contact with SARS patients had higher levels of PTSD and psychological distress. And further studies have found that staff, irrespective of contact with SARS patients, still had higher psychological morbidity than the general population. And finally, following the 9/11 attacks, researchers found a marked increase in healthcare responders reporting mental health issues. And recent studies found that these levels increase over time as a result of attitudinal barriers to seeking mental health support and a desire to handle it on my own. Next slide, please. So how can the workforce be supported through and to recovery? And through our research, we found lots of examples of protective factors that can be implemented to help the workforce through to recovery. And these include ensuring staff are given adequate time off from work to decompress, rest, and reset, and giving staff access to training and education programs. And this is particularly important for infectious diseases to alleviate concerns and tackle any misinformation. And finally, developing a supportive, compassionate work environment where staff are enabled to deliver that work, be that through support networks, access to psychological interventions, but also taking into consideration things like the need to access nutritious food and refreshments during all working hours. Next slide, please. So in summary, as we've heard before, recovery from a disaster is non-linear, and this will be no different for the health and care service workforce. We heard in some interviews that some staff had already been redeployed back to their normal service roles, whilst other staff have continued to work at greater intensity as a result of COVID patients. And this really means trying to manage psychological and emotional support for staff and of communities when they are running on lots of different tracks and at different rates. And finally, we know from the research that psychological trauma of affected staff can persist for many decades after a disaster and is likely to be exacerbated by the likelihood or even threat of future waves of COVID-19. Next slide, please. There's always a strong desire to get recovery done, and this feels in contrast to NHS recovery efforts that appear to be very focused on system resilience and recovering services and getting back to business as usual as quickly as possible. But for many individuals and communities, recovery is ongoing, learning to live with that uncertainty, threat, and risk. This work brought home many people around the world live with the constant fear of disasters. For example, we were reminded by interviewees that in New Orleans, you have a generation of people affected by disaster. Children who were born during Hurricane Katrina and graduated from high school during COVID. It's also a reminder that resilience isn't something that you can fix and move on. You have to constantly invest in building and supporting those close community connections. As one interviewee said, you can never really say you're truly resilient. You can be resilient for one thing or one day, but the next time it's something else. And the same can be said for communities and the health and care workforce too. That's why there's so much to learn about how systems and people cope and how they've learned to live with risk or living with repeated recovery. And I thought I'd just leave this quote here from the Australian Handbook on Resilience, which we thought was quite an impactful quote there to end.
Johnny, that was superb. Thank you ever so much for that presentation. A beautiful compliment to Pratibha's first presentation there. I think one thing as we prepare to hear from Richard, one thing that strikes me, of course, is that we've gone very quickly, haven't we all, as acute providers, from a dialogue around recovery, which, as we've heard so far, is very nuanced, non-linear and inherently unpredictable, to a whole different lexicon of recovery in terms of the operational recovery of a service. and the two are very disjointed. And I suggest and reflect that we haven't even properly begun the psychological recovery of a huge element of our workforce, whilst at the same time landed on our laps is now the suggestion of an operational recovery, which will place even greater emphasis on the resilience of those same staff. And perhaps that's something we can come to towards the end of the session. And with that in mind, I'd like to invite Richard to come and join us now and give his presentation. And Richard comes at this from a different perspective yet again, in terms of his role as the CEO of a busy trust, Sherwood Forest. And I'll hand over straight to Richard to share his reflections and thoughts for us now. And I think and believe that this will be, again, another compliment to the previous two presentations. And it'll all then hopefully come, no pressure, Richard, it'll all then come together in a way that will enable us to have some discussions at the end. So Richard, it's over to you. Thanks.
Thank you, Darren. Really pleased to be here and to listen to colleagues who've spoken before me. As Darren was reflecting, I think what's pleasing and unsurprising is there are huge similarities between what we've all had to say, whilst probably approaching it from slightly different directions. This clearly is about shared learning, and whilst it's about us sort of sharing our views and learning from the last year or so, and then other events that have taken place, it's also a really important opportunity to listen and learn from the wider audience. So as Darren was saying, any questions or comments are really well received. And I think what's fascinating about this is over the last year, we've been often responding to things for the first time. And there has been no blueprint for sort of the recovery, whether it is for organisations or for individuals, and certainly no blueprint for the year ahead of us. So I think the more we can do to learn from each other and to support each other, the better. It was interesting just hearing Joni talk about disasters as well. Well, 5 minutes before I was due to speak, my laptop flashed up saying that my Wi-Fi was intermittent, which felt like a disaster to me. So I've moved on to 4G from my phone. I hope it works. And it was useful to me to hear about what real disasters are, as opposed to sort of minor technical hitches. So what I plan to do for the next 10 minutes or so is talk a little bit about the context around what we've tried to do. I'm going to talk about some of the things that I worry about as a chief exec of an acute organisation, and also the executive lead for an integrated care partnership. And then I'll talk about some of the practical actions that have taken place at Sherwood. So in terms of the context, I think balancing the requirements to ensure all colleagues get a proper break this year, whilst resuming as much of our non-COVID services and care as possible, will be the greatest challenge we face. And I certainly think it will be as great as the challenges we've faced over the last 12 months. It's clear, as we have heard today, and we all knew in advance of today, that many colleagues, whether it's people in primary care or secondary care and community services, mental health services, acute organisations, specialist organisations, the local authority and the voluntary services, people are worn out, both in terms of our working lives and our personal lives. And I think it's that dynamic between COVID and our personal lives and our working lives that have been particularly complex. So we need people to be able to rest in a meaningful way over the next couple of months and to decompress. But we also know that waiting lists have grown. We know that access is a marker of quality and safety and patient experience. And clearly we know that in a world with COVID-19, and whilst we've made a magnificent national response to the vaccination programme, working with international partners, we know that COVID will be around in our organisations and communities for much longer to come. And we know that providing safe care to people will be more challenging and slow as a result of that. So I work at Sherwood Forest Hospitals. We're a 3-site acute community trust in mid-Nottinghamshire, as part of East Midlands, working closely with health and care partners. As a reference point, because I think this is about support for people, I want to reference the NHS staff survey. So we were pleased in 2020, during peak COVID, that the results from the national NHS staff survey at Sherwood indicated that for many trusts, engagement improved last year. We know that overall engagement across the NHS improved at a high level. I think that's for a range of factors. Possibly COVID has been a single point of focus that has galvanised us. Possibly, I think at times, certainly at the beginning, COVID was something that may have excited us, but also we know that the NHS and the wider public services have received a lot of recognition. And I think that has resulted in increased pride in the care that we provide through the NHS. At Sherwood, not only did the engagement improve last year, but we've now had 5 consecutive years of engagement as measured by the staff survey. And of the 128 trusts, we're second in the country for morale, and we were 3rd overall for people recommending this organisation as a place to work. We're also currently the Health Service Journal Acute or Specialist Trust of the Year. And that's because we believe that we look after the people who look after the people. So I'm trying to not just say this is a great organisation because we have problems like everywhere else, but I'm trying to set that context to explain some of the things that we've been doing. I do recognise, though, that there is lots more that we need to be doing. And I do know that not everyone at Sherwood has felt supported during COVID. And very sadly, I'm aware of NHS colleagues who have taken their own life or attempted to take their own life over the last year. And I think that's a concern and a risk that we will have for many years to come. So that's something that we need to be really focusing on. In terms of concerns, we employ 5,500 people at Sherwood. We work with 5,500 people. And I worry, or I'm concerned about 4 groups over the last year and for the year ahead. So the first bit is I worry and am concerned about colleagues who have been caring for patients with COVID. They have experienced lots of trauma, they've experienced lots of death. And I think the physical and the psychological impact of wearing PPE for long periods of time will be huge. Another group I worry about is I worry about our lowest paid colleagues, whether they're porters or domestics or housekeepers. And on occasions, and I wouldn't disagree with them, they feel that our organisational response has overlooked them over the last 12 months. We need to ensure that they are also at the centre of our thinking as we move into the next period of time. I worry about colleagues who have been working from home 5 days a week for the last year. They've gone from on-site working to working from home. And I know that colleagues have experienced isolation, anxiety, or another feeling of left out. Those colleagues are now returning back to work, flexible working, and we need to ensure that they feel included. And the final group of the 4 that I worry about is that catch-all. I worry about everyone else, because whilst we've been in it together and there is that real sense of teamwork and camaraderie that colleagues have spoken about, I also recognise that we have not all had the same experiences and we will not all feel the same today or feel the same for months or years ahead. So some of the practical things that we have been focusing on at Sherwood over the last 12 months and we will continue to focus on for the near future. The first bit is we have a fairly well established improvement cycle that runs through the organisation. So Jim Collins is an American author that many people will have heard of, and he talks about improvement or transformation. What he says is no matter how dramatic the end result, good to great transformations never happen in one fell swoop. They are more to do with the process resembling relentlessly pushing a giant heavy flywheel, turn upon turn, building momentum until a point of breakthrough and beyond. So what we have tried to do over quite a long period of time now is focus on 5 interlinked things. And I think this has been at the centre of our response to COVID. The first bit is about looking after people, ensuring that we have a very clear culture in this organisation that people buy into, making sure that people feel included. The second point building on that and is relentlessly focusing on retention and recruitment. We have wonderful people here and we want to be recruiting wonderful people in the organisation. And when I think you change the culture in the organisation and you change your ability to recruit and retain, I then think you can really focus on the third step, which is doing everything possible to ensure that patients receive safe, high quality, timely care. The penultimate point is communication. I'll touch on more about that, the importance of communicating the narrative, as other people have said today. Then the final point is about working effectively with partners. And because we've got good foundation stones in this organisation, we have been able to work effectively with partners across mid-Nottinghamshire, focusing on being a great partner, but also a humble partner. The second thing that we've been looking at is focusing on the physiological needs. And I believe the physiological needs of people are what people need most of the time. People need to ensure that access to money, whether that's being paid on time or paid correctly. We're focused on being a good local employer, and also during COVID, ensuring that people had access to food. If you think about the hierarchy of needs, the most basic level is our physiological needs. And for NHS colleagues working long clinical shifts, this translates as rest, rehydration and refueling. We haven't cracked that at Sherwood and there's more we need to be doing. Another thing we recognised early on during COVID is the economic impact, and we heard that people talking about that earlier. We know that it's disproportionately impacted on our lowest paid colleagues and their families, so we set up a financial hardship fund to support them. And then also passionately believe in the impact that loneliness has had on all of us in our working and our personal lives. So over Christmas and the New Year, we set up mechanisms to ensure that colleagues did everything possible to ensure that colleagues didn't feel alone or isolated over that difficult period of time. Another thing we've been focusing on is engagement, whether that's some of the stuff that Roger Klein has spoken about, inclusion for all colleagues, whether that's ensuring that colleagues feel that they have been in the room when decisions are taken. So at Sherwood, we know that change is easier to deliver and more likely to work if people feel they're in charge of the change. So we've actively involved all colleagues in our decision making. Nottinghamshire last week or the week before was identified as one of the 12 integrated care systems that's been given additional funding to support elective recovery. Our decision to be involved in that came from the clinical and non-clinical colleagues involved in patient care. And we also know that trust dictates the pace of change, and we've been taking active steps over many years now to improve trust in the organisation. The penultimate point, and we've touched on that, is about communicating the narrative. We have tried a whole series of ways, whether that is through personally written blogs on a weekly basis, virtual staff briefs, within the limitations of COVID, getting out and about in the organisation to communicate what's going on. I think it's really important that organisations and senior leaders don't just simply communicate the good stuff. We also think it's really important that we communicate our personal vulnerabilities and the challenges we've had. And I think whilst it would be nice for us always to have the answers, I think people are receptive to the honesty and the truth. And we actually, I haven't got the answer to that, but let's talk about the steps that we're trying to take to resolve it. And then finally, I was going to touch briefly on some of the things that I've personally done. At the moment, I'm communicating on the things that are worrying me at work. So I worry about how colleagues feel. We can seek a place of solace about the strength of our staff survey last year, but the reality is that's 7 months out of date. I think we need to have a more effective way of understanding exactly and accurately how people are feeling. I worry about the patients who have experienced harm and the process that we have in place to restore our services. And I worry about whether we are fully maximising the opportunity of recovery and restoration to reduce inequalities, whether that's health inequalities or to reduce the inequalities of people experiencing at work. So I think the NHS is fantastic at caring for patients, and there's growing recognition that cultures truly based on inclusion, on kindness and compassion make a real difference. But we also need to think about ourselves. As I've said and others have said, we've all experienced a range of emotions. The leaders I admire the most are the ones who are the most open, are the most honest about their feelings, and also share their personal vulnerabilities. I think we must remember that to effectively look after others, we also need to be kind to ourselves by role modelling an inclusive culture and a better work-life balance. So I will finish there, Darren.
Thank you ever so much, Richard. That was really engrossing for me, actually. And from my perspective, you're right in terms of the learning from that latter presentation you just gave there, which for me was all around that honesty and that vulnerability of senior leaders, and I think that's so important. I would suggest at this time now, that's what's been a huge learning point for me through the course of the pandemic. Conscious of the fact that we've had 3 back-to-back presentations there from very different perspectives, but beautifully complementing each other there. I'm very happy to open up our group to any questions that delegates might have. And while people are thinking about a question and maybe wanting to raise a hand or a question in the chat box is equally welcome. I think for me, just to get your perspective as 3 panelists, I think everyone's mentioned compassion and kindness in their presentations to a different degree. And I wonder, perhaps going back to the start to give Richard and Joni respective, whether you would care to just say a little bit more about what compassionate leadership looks like to you and what you've seen around compassionate leadership and how that might need to change in future, just by way of an opener while people think of a question. That's one thing that strikes me. What do we mean by compassionate leadership going forwards?
I guess from my perspective, and Richard's kind of articulated quite a few of the kind of key elements of it, it's really recognising, I think, the challenges there are in the system at the moment and being able to actively listen to people and our staff and to recognise that this has been incredibly challenging, that our staff are really diverse, all of them will be at very, very different places, but really kind of that listening, that validating, And Richard mentioned the modelling, which I think is really, really important, actually, and that kind of that vulnerability. It was really interesting. I don't know whether some of you remember Grenfell from 2017, and the fire chief at the time actually talked about our own mental health. That had the most powerful effects actually on engagement. So our ability, I think, to sometimes model our vulnerabilities, talk about our own well-being, our own mental health, I think can be incredibly important. But just kindness, listening, validating, I think are some of the kind of key elements for me.
Yeah, absolutely. Thanks ever so much. Yeah, they're great points. I'm wondering, Joni, from your perspective, you mentioned in your presentation, you showed us that graph about where we might be on the journey, and it's a graph that looks like a relief map of the Pennines. And I'm just thinking about, from your perspective, anything we'd want to say about that sort of that amazing graph of about where we might consider ourselves to be, and where, in your estimation, the NHS, it's a big question, the NHS currently is on that graph, if anywhere.
Yeah, I think that's quite a big question. And I think kind of going back to points that Richard and Pratibha have made, it's really important to acknowledge that people will be at different points on that graph within the system. And so, the NHS as a whole we may well think that we're at a point to start thinking about recovery. It's really interesting to hear some people starting to talk about that. And I remember when we first started this research piece, actually, we started this research kind of quite early on in the first wave. And so if you'd asked me back then, I think we would have been in a very different place. And there was almost a kind of, there was no space to start even thinking about the word recovery. And I think we've moved on from that. And I think we all understand that actually there's no good time. You kind of have to start working on it now. In terms of a more general sense about where I feel we as a nation might be, I think it feels like we're kind of slightly feeling quite optimistic about being, slightly coming out of the disillusion stage. I don't know, with lots of context and things, but there's always the possibility. And that's the thing, isn't it? It's not an easy upward trajectory. There are always things in context that will potentially move us up and down that graph. It's a big one. It's going to make me think about it later as well. Sorry.
As well, Richard, from your perspective, in terms of being the CEO of a large healthcare trust employing many thousands of staff, obviously, like all of us, COVID-19 has given us pause for thought around the psychological offer for staff, and that's been mentioned several times as well, of course. The well-being often, it goes way beyond Rocky Health, as was previously what we all imagined as a shortcut to staff well-being was sensible talkie health. What are your reflections on how you as a CEO might need to beef up, bolster, refine, expand the staff offer around psychological well-being in perpetuity now, the way it might have to now look in an organisation your size, which of course will come with the necessary investment, like all of us, and none of us have got any cash. So how do we square that circle, do you think, Richard?
So we were really fortunate that for a range of reasons at the beginning of COVID, we recognised that COVID would manifest itself in a whole range of ways that would have a psychological impact on our colleagues. As we've described, that may manifest itself in one way for one person on day one, and then another person would experiencing something completely different sort of 12 to 18 months afterwards. So very early on, we partnered. We've got Nottinghamshire Community Mental Health Trust, who are our local mental health provider that we've got very good relationships with. And they were fantastically supportive about offering colleagues a whole range of support, whether that was sort of psychological one-to-one into some of the hardest hit areas like critical care or the respiratory wards, or a whole range of other sort of virtual offers that could be picked up by bigger groups of people. And that worked really well. We've had 3 discrete waves of COVID in the Midlands, and on each 3 occasions, we've sort of put in more and more resource. We know that, as you described, money is scarce, but we have disinvested in other services, or we have proposed that we will delay investments in things because we view this as incredibly important. In the conversation now is about what is that offer that's required over years to come. And I'll just go back briefly to the point that I made. The bit that I worry the most about is I don't really know how people feel. I know how I feel. I know that I'm struggling at times. I know how the executive team and people I work with on a day-to-day basis are feeling, but I don't really know how the wider organisation feels. And for me to understand what our offer needs to be, I think we need to have a better, sort of richer understanding of what people are experiencing at the moment.
Thanks, Richard. That's really helpful. And I think I know we're getting to the end of the session now. And I think for me, one thing that I found in my role very necessary is that reflection about how it's changed me as a person and how I come to work now thinking differently. And I wonder if it's not too big an ask, perhaps going in reverse order again. Richard, perhaps you might start us off on this. How has it influenced when you come to work in the morning now? How's what's happened in the past year and over all these months now? How's it changed you as a person in your professional role, Rich? How do you think you come to work with a different mindset, different mentality? How's it changed you as a person on an individual level every day?
Wow, that's a huge question. How long have we got? How's it changed me? I think it's made me. Far more. I think it's part of a wider evolution. So I'm a pretty reflective person anyway. I think I've become more reflective over the last 12 months. I think I have, like all of us, certainly as we're moving out of current restrictions, I think I'm now, and I hope I'm able to embed this. I think I'm more grateful for some of the things that we took for granted previously. So spending time with friends and family. I'm also, I think the bit that I've really reflected on is just how interlinked our working and personal lives are. So people put on a brave face, come to work and you assume everything's fine. Well, I've had a couple of challenges in my personal life over the last year. And I felt, as one of the colleagues was saying, when I've referenced that to the organisation, suddenly you hear about what people are going through in incredibly sad situations that many people are in at the moment. So I think it's really made me reflect that we're fortunate to be surrounded by great people and we need to do everything possible to look after them.
Yeah, thank you, Richard. That's so true. Jodie, from your perspective, from your angle in the research you've been doing, how do you think on a personal level with the work you've been doing, how's it changed you as a person being involved in that work, do you think? What do you take from it?
I think it is a really interesting question, and unlike my colleagues, are probably slightly further away in terms of my role as a researcher. So I'm kind of blessed in that I get to work slightly removed from the kind of real pressure of the system. But even as a researcher, right at the beginning of the first wave, when we were asked to look at this work, looking at recovery and really going into a lot of depth about the impact of disasters, and particularly my area of interest around health and care workforce, it did feel kind of at that point, it was kind of like you're living it in your real life, in your own day-to-day life, but you're also spending all of your working life thinking about it. And I can't even begin to imagine what that feels like as a frontline member of the NHS staff. I just, so for me, that it was hard enough kind of just getting into the detail of it, researching it, talking to people who were experiencing it. On a very personal level, I'd really reflect on the things that my colleagues have said about senior leadership, modeling some of that behavior. And we've had some of that at the King's Fund. We've all had to real huge changes to our working personal lives. And as my own, experience, some of our members of our SMT opening up about their own experiences, for me, it's felt like it's had a real cascade effect across the organisation, where some of those things are just a lot more on the table, and everyone is able to kind of bring that to work without kind of fear of feeling like they had not delivered or weren't being as good as they could be because they were struggling personally or whatever it was. So yeah, I think those are my main reflections.
Yeah, no, that's really interesting, and thank you for sharing that. It's so powerful to hear those reflections, Jodie, and back up to the northwest, and particularly my colleague, you were there waiting patiently. What's your reflection from? You got several important roles, and you've melded them all together in the presentation you gave us. And what's been your personal sort of journey of change, you think, and how are you different as a person coming to work now than you were before this all started?
I think it's probably just to kind of add to what Joni and Richard have kind of said. It's been an incredibly challenging roller coaster of a year with ups and downs. And I think the ability to provide compassionate leadership actually does require you to look after your own self-care. And it was really interesting. One of the key differences between COVID and the arena attack and acute incidents are a single incident event, really. And this has been an absolute roller coaster. And, you know, a number of people have alluded to, we just don't know what the next sort of 6-12 months are going to look like. You know, we suddenly haven't kind of come out of this completely. So the real focus, I think, about looking after yourself is going to be critical, because if we want to be able to support teams, if we're exhausted, actually that becomes incredibly difficult to be able to provide compassionate care. So I think Richard and Joni have kind of alluded to that. Do look after yourselves. Quite often we're not so good at doing that.
Thanks ever so much. That's a great wrap-up concluding comment there. You're so right. I'm very conscious that we're slightly over our time here, but I'm sure you'll agree with me, all of you who've attended this session, that it's been so great to hear these three different perspectives, and the commonality about what's been said has been striking, hasn't it, from the three contributors there, come at it from very powerful, well-informed perspectives. And there's lots of learning for us all there in this session, a lot of learning, and it's a shame it's as brief as it is, and it's a subject undoubtedly I think we'll come back to again and again in weeks and months to come. But now, conscious of time, so we don't get into trouble for running over time, I'm sure you'll all join me in thanking our three contributors today for such a great hour or so. And I hope you enjoy the rest of the conference to come.